I'm working as a medical aid. So for you all to know that the meeting is also being recorded. So yeah, you probably might have the slides later. So I'm saying I'm Saba. I'm one of the medical aid doctors. I'm currently working in the NHS, and it's been a couple of years for me joining the NHS. It's a good experience. Um, I'm currently working as a psychiatry registrar, and you might think why I'm here today. It's just that no matter which specialty you are in, I was telling them earlier as well, or which exam you were preparing for, the whole idea, because the webinar today focuses on communication and history taking skills, and the whole principle of good communication remains the same for any exam, for it, whether it's your MRCS, MRCP, MRC Psych, or whatever, even if it's PLAB. Because whether you're explaining a diagnosis, you're taking a history, you're handling a difficult conversation, your ability to communicate your thoughts clearly, respectfully, empathetically, it is what creates that environment of you and the patient having that good therapeutic relationship, feeling them feeling safe, and you providing them and treating them effectively. So I'm today here and I'll talk you through how to handle a communication-based skill station in MRCS exam. When I say communication station skill, I would still like to say that it is one of the easiest and an easy way to secure good marks in the exam, provided you have one, a good structured approach to your and a theme to whatever you're doing, and you've practiced enough, you've practiced it thoroughly again and again. When I say having a structure, is it because it makes you minimize the chances of missing any potential critical points that might be important for you to come to that conclusion, to that diagnostic conclusion. So, because most of the times we do have a question bank, or we have scenarios that are quite similar to what might come in an exam, but on and off it does happen. There's something difficult, or a new scenario turns up. But if you have a certain structure in your head, you might be able to take it through very easily without much difficulties. Uh, we often hear, as IMGs, international medical graduates, we often hear people saying that English is not our first spoken language. We're not really good at communication and conversations, and it's generally a concern. But it's not that you don't know how to speak, or you can't speak, but it's just that it's not your language. But the good thing about is that communication skills, particularly for your exam, any exam, it's a learnable skill, I would say. The more you learn, the more you practice it, not just practice it with the partner, with someone, speaking it out loud, even in front of the mirror. It does make a difference, and you're able to see the change in yourself. And I always say that think of any station just as a focused conversation between two individuals, you as a professional, and the other, and someone on the other hand as a patient, just to come to a to final conclusion where someone is receiving something good, which is in their best interest. When I say this is because, particularly talking about NHS, not back home. We're looking at patient-centered care. So patient is the main focus which you're looking at, and you treat them as the hub, as the center, and then things revolve around them. So you're mainly focusing on and considering them as uh, someone very important, yeah. And then you're able to treat them respectfully, and then you're clearly communicating things and stuff. Uh, I'm sure because um, you're already aware of the pattern, the structure for your exam. With the history based, it's like two stations, each lasting 10 minutes, carrying a total score of 20 marks. You've got 1 minute to read the stem outside when you're outside the cubicle, and you've got 6 minutes to take the history from the patient, and then the rest of the 3 minutes is to present your case with the examiner and answer their questions, if any. The patient you have is an actor, and these actors are really, really well. They can just carry away. You can get frustrated, but they're so well, they act so well that they can actually throw you off. But as I said, having a structure, it just helps you stick to your basics, and you're able to contain that and just lead the conversation, basically command, have that command in that room in your hand. Basically, that is what you want. um, and there are two examiners present in the station, in each station. So you've got a medical professional, who carries 15 marks with him, which is looking into how you come, how you take the history, what is the history gathering skills you have, and they're also looking into how you explain, communicate, not particularly communicate, how you summarize and answer the questions. And the other five are with another one who's a non-medic. Is just a normal, someone random, who's just looking at how you're talking to the patient, uh, in terms of a layman, how your body language is, and how you're basically talking to the patient. Yeah. Uh, Yet again, so we discussed this very extensively because we started a bit earlier. Apologies for that, but I'll still try to just briefly explain as to what it is. So. This particular station is like history taking station, where you make sure that never forget to introduce yourself. One, you enter the cubicle, you've got someone there, you enter the room, you sit down, you introduce yourself. Good afternoon, good morning. I'm Dr. ABC. I'm one of the surgical doctors in the ward, and I'm here to do so and so. How can I help you? Whatever. Well, before that, actually introducing yourself, and then not forgetting to ask the patient who the patient is like. How may I call you today? How may you like how do you like me to call you? So you're Mr. Jones. Is that fine for me to call you Mr. Jones? Yes. Could you confirm your date of birth for me? Okay, yeah, great. This is perfect, brilliant. Let's get started, Mr. Jones. I'm sure that you're aware that we'll have a good a few couple of minutes for us to have a conversation. Is that right? Yeah. Is that okay? Yeah. Okay. And then you ask about what brings them to the hospital, how you can help them, what are what was it that brought them to the hospital, and always make sure that whilst you do that, it's an open-ended question, because it helps you to get as much information as someone would want. Because with a closed-ended question, the patient might have a different thing in his or her head. But asking closed question would mean that things are getting bypassed, and you're not getting the real answer, actually what the patient would want to talk about. So it's always good to ask open-ended questions. And then we'll talk about, for example, it here says that someone coming with pain and stuff, for example, abdominal pain, chest pain, whatever, in your head, because you want to take that history and you want to come to a conclusion, you want to make that diagnosis, you want to summarize it to the examiner. But make sure that you are equally engaging the patient. The patient, it's not just you talking throughout that station. It's a to and fro conversation between you and someone sitting on the opposite end, right? So let them speak, give them time. Yeah, make sure that they're listened to. For example, someone coming in with pain, you just don't start there and then. You make sure that they're comfortable. You ask them whether they're comfortable enough for them to continue the consultation or not, or they want some sort of pain relief or something, before they can like engage further in the conversation. At least you're acknowledging, and you've offered them something. Yeah, it gives you some, yeah, tiny money points, which are important when you just club them together. So making sure that the patient is comfortable before you start taking the history. And then I'm sure we won't go much into like what the history taking exactly in the steps are like. So because I'm sure you're aware of presenting complaint, and then you elaborate that as to what is that. If there are two complaints, you just uh, go one by one. For example, okay, one was pain and there was one in vomiting, the third was fever. So you just elaborate all of them. And then the next thing is that in your head, because these are the complaints, but you want to come to a conclusion, you want to make that diagnosis, but at the same time you don't want to miss any emergency, you don't want to miss any red flags. So make sure you have and you try to rule out at least two or three differentials when you're doing that. When I say differentials, you have two or three specific questions, because of course every every condition will have one or two particular questions that are significant, that would separate them from the other, basically. So you make sure that you ask those questions explicitly for the examiner to see that you're ruled out emergencies, you ruled out other possible factors that might be contributing to this, and which made you think that this is eventually the diagnosis which we decide it is. Okay. uh, so rule so when I say presenting complaint history, presenting complaint, the next thing is that ruling out red flags. And then the rest of the history is, I mean, all of us have been through medical schools and we know what it is like, asking the past medical history, any relevance, any recent illnesses, any past surgical, any allergies, any medications that might interact, might have some significance whilst you're doing what you're doing, or might have led to what they're experiencing now. And then the rest of it is more like social things, family history if it's relevant, social history if it's relevant, personal history if it's relevant. But yet again, whilst you do that, whilst you go step a bit like outside of medical things, for example, social and personal, you are asking it because you know it's relevant. But for someone, a layman, he might not think that drinking alcohol smoking is related to some other illness he might have. So make sure that you always signpost and you always tell them, debrief them. Okay, Mr. John, thanks for answering all my questions so far. You probably might have to bear with me for a couple of more minutes, couple of more seconds. I have a few more questions to ask, and these are questions related to your personal well-being, personal, your living thing, your social factors, other things involved. I'm asking only because these are relevant here. Is it okay for me to go ahead? So something along those lines, just to make them aware that you're going to ask something different besides the medical conditions that you think is relevant, and always try to explain it to them as to why you're asking them when you're asking something. Yeah, and always thank them when they answer you. It's just that you got the answer doesn't mean that's enough. They've answered you. You need to be like, show some sort of gesture, a smile, a nod when you do that. Yeah. And then whilst you've come to personal, social, family history, you've completed all of that, you just try to rephrase, summarize. Okay, Mr. Jones, just to make sure that I've got it correct. You said a couple of days ago, this happened, and this led to this, and that you tried this, it did help, which made you think you should come to the hospital. And at the moment, it looks like you've got this. Is that right? Is there anything I'm missing on? Have I got it right? Brilliant. Thanks, Dr. Man. Thanks for bearing with, thanks for your time or whatever. Make sure that you familiarize yourself with, see how I am struggling at the moment, like giving you those brief phrases, right? So you might think in the exam it might come naturally to you. No, it wouldn't. You have to practice them. Familiarize yourself with few, uh, you know, sentences, some phrases that you can use them in any scenario, in any situation. So this is basically until that. But the most important part of history taking, yet again, is to come, which is eyes. You ask about the patient's ideas, you ask about their concerns, you ask about their expectations. There's no hard and fast rule as to where and when do you ask them, but make sure you do. It might be after you complete your, for example, before going into family history and start and asking the next other question about personal and history, you might ask, okay, John, you've said this, and this. What do you think has caused it? What do you think has led to it? What do you think could have caused it? Where do you think it might be stemming from? What is your understanding? Yeah, okay. And then you always thank them for what they've said. And the next bit is about, besides this, you've given me a lot of information, which is very useful. Do you have any other concerns? Do you think there's anything else you would want to talk about? Anything that bothers you? Anything that's more concerning? Is there anything? And then you always ask, okay, John, you came to the consultation. Did you have anything specific in your mind? Were you expecting anything different, or was there anything that you had come up in your head with that you wanted to discuss with me today? Was I able to clarify on those things? Were we able to talk it through during the consultation? If not, we still could you do you like to mention something that you think is important, or basically something along those lines. This is a general overview of how you take a history. But more importantly, as I said, English is not our first language. So things might sound you might sound like you've just uh, crammed it. It's not coming naturally. So you have to work on those areas basically. A lot about how you're talking to the patient when you're talking to them, how what is your tone like, what is the pace like. It shouldn't sound very monotonous. So you should have like highs and lows when you're okay. Like it can't be like a monotonous tone. You're talking for a good 6 minutes to the patient. You have to do it. You might not do it in a real life, but in the exam you need to do it, and it comes with practice. It's not a big deal. You need to do it. Uh, Staying very calm whilst you're talking to the patient. You're listening to your body, leaning a bit forward towards the patient, calling them by their names on and off. Yes, John. Yeah, you said that. That's right. It makes a difference. Yeah, it gives you that. The examiner can see that how confident you are through your body language. They can say it. They can clearly score you on that for all of this. Yeah. So make sure that you speak very clearly. You're not too fast. You're not too slow. You're taking that pauses. You let the patient speak. You ask them, John, am I clear? Was it clear so far? Have I cleared it so far for you? Is there anything you want me to repeat? Um, do you want to repeat it? Do you understand what I've said? Is it clear? Okay, all of that. Yeah. Uh, Other thing, well, when I say leaning forward, calling them like calling them out by their name on and off occasionally. Don't call them like mistakenly by a different name. For example, one station they might say John and the next might be Richard. So make sure you're not calling out the wrong name either. So but it always sounds good. That's what I mean. Uh, and then actively listening to the patient. So you have to pick on non-verbal cues, any gestures the patient is making. It's not saying, but you can see. Okay, he's not able to clearly explain it to me. Are you struggling to explain anything to me? Is there something that's troubling? Yeah. So you have to pick on those things. And whilst they're giving you that history, they're explaining things to you, you're listening to them, you're nodding your head, making sure that yeah, they being examiner notices that you're actually listening. You can give them brief affirmations like yes, I can see that, yeah, you good, go ahead, yeah, I can hear that, I hear you, yeah, keep saying yes, good, yeah, and just maybe even just nodding your head and just reflecting back in between sometimes, not just to like, oh, no, I don't mean to like say that you shouldn't interrupt the patient. But yeah, once they stop, you then reflect back on saying that okay, John, you said that the pain started here, or it starts when you eat. Is that right? So something just a brief. Don't worry about like it's going to take a lot of time. That's what why I'm saying that practice, practice, and practice. It then would come naturally to you. Yeah. And then always try to create that environment, that space where you're empathetic, you're giving that reassurance, you're acknowledging their emotions. And when I say acknowledging your emotions, it is by verbalizing those phrases. Yes, it might be worrying for you. I can see that. But I'll make sure that you get the right support and make sure you get as much support as we can offer. Yeah, something along those lines. And make sure, yeah, it's important to sort of check their understanding, because sometimes what happens is that you just go on and on and on and on and on, and by the end, imagine the patient saying, "Doctor, I wasn't with you whilst you were saying that," so it is a disaster. So you keep on checking and asking them, is that clear? Is that clear? Do you want me to repeat? I'm repeating that again and again because it sounds very it's like a mere thing, but it carries marks. It has some weightage which you need to get for you to get through the exam. And I will again say that have that structure in your mind. When you practice, have a structure, make your own structure, because it will help you save time. Is that clear so far?
Yes, it's clear. Yes, please.
Great, thank you. All right. Okay. Uh, these are some of the topics. Uh, that I'm sure you're aware of again. One of my colleagues who's done his MRCS is of the opinion that these are the most common ones that you can encounter for any exam, any Royal College exam. They always have, there are few, well, not just Royal College. There are always like important ones, important topics that you're aware of, and it might come in one or the other way, and you have to be familiar with them. So these are the most of them which you should be able to like um, practice. And don't think that you've practiced, for example, inguinal hernia, or you've practiced maybe lower limb claudications, and then the other one you might be able to do it on your own. No, you need to practice them separately, each case separately. They're not, I don't think there are many. I don't think they're more than 50 or 60. 60 is not a huge number. If you practice like two or three a day, you should be able to get them sorted in a couple of weeks. Where are we now? Okay. So I don't think I'm in that position to discuss each of these cases separately, but I hope like a general overview as to how you should approach a history-based scenario was clear so far. These are like scenarios how you would see them outside the cubicle. For example, I'll just read them out for you. You're a surgical SHO on call and you've been asked to see a patient A&E who has abdominal pain, and please take the history from the patient. And then there's another one, it's a pre-admission clinic and the patient has been experiencing occasional chest pain, so please take a history. So in your head when you're outside, in that 1 minute, it took me a minute to read that, right? But I now know that there's a patient inside who has come for a pre-admission assessment and also has been experiencing occasional chest pain. So in my head, I know which system I have to focus on, yeah, and make in my head outside the cubicle. Try to recall one or two of the differentials outside the cubicle. So think of P, think of MI, think of like ACS, think of pericarditis, so whatever. It probably might not be relevant for me, just giving you an example. So outside, just try to like start thinking of the station outside the cubicle. It doesn't take you a minute to read the whole stem. Yeah, that's similar. An orthopedic SHO getting back pain, take a history and present the findings to the examiner. So basically, it's just taking that history, whatever we discussed so far. We'll see if we've got enough time at the end and you have questions, we can then take them. And the next bit is like communication, is still communication skills, but it's like communicating something with a patient or an attendant. And there's this one where you talk to a healthcare professional. So these are different. One is a face-to-face where you talk to a patient or an attendant, and the next one is where you talk to a medic, basically a medic over the phone. So yet again, there are different scenarios. I'm just so self-discharge, OGD, consent for OGD, anxious patient counseling, angry patient counseling for knee replacement, consent for colonoscopy. These are like all, even explaining a diagnosis, OGD, counseling, breaking bad news. One, this is one, uh, and we'll come to the consultant in a bit. Even for those stations, communication with the patient, I would I'm of the opinion that structure is very important. If you have a structure in mind, you won't get distracted. Because oftentimes what happens, the patient, they have 100 different things to talk about, and they can just troll you anywhere and everywhere in that direction. So you have to hold that lead that conversation. So having a structure is always important. But basics first. You always introduce yourself. You ask them about their name, what their date of birth is like, and let them answer. Take a pause when you hear them. For example, I'm being asked, "Who am I?" I'm saying, "Well, my name is Sabah. I'm age 40." Uh, you then reply back to them. Okay, thank you for answering. That's good. That's good to know. Fantastic. Are you okay for me to continue the consultation? Continue the conversation? Yes. Thanks. Thanks, John. Whatever. Yeah. And I personally think it makes a huge impact when you call the patient by their name. You don't, you don't have to do it like with every sentence, but try, try. It will happen. There was this one scenario which was quite. I'll just briefly to pick it up because just to make sure that you understand what we're talking about. Counseling a patient before stopping warfarin. So I just read about it. It looks like there was a patient who had been on warfarin for a couple of years for his metallic heart valve, and he is due for his surgery, and he's been told to stop the warfarin, and he's quite apprehensive about stopping the medication because the cardiologist had told him that he shouldn't stop it whatsoever because it could put him at risk, which is quite genuine, isn't it? So how would you approach that? How would you approach that? How would you want to address and approach that case? There's no rocket science. You have to uh, I think it's not difficult if you stick and remain see yourself whilst being a patient. Yeah, try to see yourself as a patient and imagine how would you want to be explained coming off a medication that would put you at risk and is life threatening. Yeah. So I would I'll just give you an example. So I would say, Mr. John, I was told that you're concerned about your warfarin tablets, which you've been advised to stop before your surgery. And I've been told that you have some questions and you wanted to talk a bit more about it. Is that right, Mr. John? So he would say yes or no. So just to say that, okay, this is the topic. You're just giving them a heading that this is why you're here and this is what you want to talk about. The patient might then talk about, okay, this is my concern, this, and always make sure that you acknowledge their concern. You'll have to speak it out loud that, yes, John, this is a valid concern. I'm glad that you brought it up. It's really appreciate that you brought to surface. You come to discuss it with me, and this concerns you. But let me I think I've got enough answers for you, and hopefully by the end of the consultation, you should be in a better position and be more relaxed with this decision. So when you're telling them, you're trying to see what is their understanding of the situation, of the scenario, as to why they're being told to stop the warfarin, to stop the medication. So you try to understand, okay, John, you that is what you think, that is fine. Do you have anything else? Okay, no. And then you explain to them, this is the reason why warfarin is advised to stop. How it works is a layman wouldn't know. He's just being told it shouldn't be stopped. So you need to tell him that, okay, this is the reason you were put on the medication for, but at the moment you're going to go through a surgery, which would mean there's a risk of bleeding. It puts you at risk of complications. Hence, the safest and the best option for you is to come off it. But what are the alternatives you're giving them? So you discuss the other alternatives. For example, in this case, you would say that you'd give them heparin. He doesn't. A layman wouldn't know what a heparin is like. And if it's the same medication as warfarin, why not heparin? Why not warfarin? Why heparin? So you need to clear to them. You need to explain to them as to why you're doing what you're doing, right? It doesn't You don't have to go into that extrinsic and cascade coagulation pathway. You just have to, and you definitely don't use that medical language. Very basic, very layman terms. You have to say that bleeding, how it how the medication works, what is the duration of action, what happens if you stop, what is the reversal like, all of those things. So just to explain to them that you know what you're doing, and just taking that responsibility and accountability of what you're doing, and making sure that they understand. And whilst they definitely would understand what you're saying, and then asking that if you have any other concerns, and then addressing those concerns as well. I did read in this scenario that he was asking about some other medications, and then the post-op stuff, whether he would want to, he'd had to stay in the hospital, whether he needs to stop other medications, his routine medications he's on. So counseling stations are more like, it's like a general conversation, a conversation between two individuals, but just make sure that you're engaging the other person equally, and you're listening to them. You're making sure that they're being heard, right? I wouldn't go into detail as to what the scenario in itself is like, but it's just what it should be, how you should approach it. And there's There's a very common one, like we just you know get baffled with, and we're worried about, like breaking bad news is a huge one we worry about. Um, Staying calm, keeping hold of your nerves whilst you're doing that, because definitely, as I said earlier, those patients there, they're actors, and they act really well, uh, and they can just make the whole thing go really bad. So you just have to lead the consultation, and keep hold of things. Uh, while breaking a bad news, I think, I don't know why, but I'm always fixated to the idea of like having a certain structure. For example, for pain, we have this Odipara, we have Socrates and stuff like that. I think there's a good mnemonic for Breaking Bad as well, which we call as spikes, Spikes, where S means setting, P is perception, and I is invitation, K is knowledge, E is motions, S is strategy. So when I say setting, it's like, for example, I'll just give you a brief example. So you say, "Hi, Mr. John. Thank you for seeing me. Can you kindly sit down and have a talk about your? Can we talk about your illness?" So it's just the setting. Okay, you're explaining, you're introducing yourself, you're checking who the patient is, checking their identity, and then asking them that you're there to talk about something, talk about that their illness basically. And then before you start that, P is perception. Before you would say that, okay, John, before I go into detail, can I ask, what do you understand about what's going on in your whatever? So what do you think is going on? Why are you here? What brought you here? What have you done so far? What do you know? What has been told to you? So just to get their understanding as to where they are basically. Imagine someone doesn't know that they had lung biopsy was taken, and it was taken just to see whether it was a benign or a malignant thing, and then all of a sudden giving them, breaking that bad, that this is a cancerous growth and stuff like that. How would they take it? So just to see as to where they are. And an invitation is more like, you you ask them, would you like me to explain it to you, what the treatment is like going forward, how we can help and support you? Is that okay? Do you want me to explain it to you any further? Do you have any further questions that you want me to answer? And knowledge is that, um, there is when you that is when you start to sort of summarize the situation. For example, you said, you came in with a chest infection. It wasn't responding well to the treatment. It didn't respond well to the antibiotics, and you have had like antibiotic resistance to antibiotics or stuff like that, or whatever. And I wish, I've got something to tell you. I wish the news was something more positive, and I had something else to say, but and then you break it in layers. Basically, you break it, and you just don't say you got cancer. Just break it. Okay, we did this, and it looked like this, and then this. Fortunately, and at the same time, imagine someone being told that you've got something difficult is now happened has now happened in their life. So obviously there's this normal response, like your emotions. You'll see different emotions, anger, or maybe someone is like unable to hold themselves. Yeah, someone might cry, someone might shout. You don't know. You just have to make sure that you you offer that reassurance, you offer that support. You tell them that you understand it's so upsetting, but we'll make sure that we can offer you the best support. The news isn't really positive, but it's not something we don't see very often. This is not the end of the world. Yeah, so you have to create that. Just because it's not a positive news, you just don't have to go with the negativity and just get flown with the environment, with the aura around. Yeah, so you have to just support them and say that you you are there, and you will make sure that you offer them whatever you can offer. The medical team is there. And then it all it so I would say, break it in layers, be very sympathetic, and reassure, and support is what you can offer in that scenario. I hope that is that is clear. Is it?
Yes, absolutely. Yes, please.
Great. Perfect. All right. Okay. Uh, what else? This is now we've got communication with a consultant, right? So you're speaking to a consultant or any medical healthcare professional. So you'll be given a scenario. You'll be in a room. Then they have all the information. You'll have all the information there about the patient, how they presented, what are the vitals like. You get to I'm not really sure about. I can't remember how much time you get that for. And then you go to the next room, you go to telephone there, you have to call the patient, sorry, the consultant, and you have to discuss the whole thing and um, maybe ask for advice, ask them to come or whatever. So these again are the few of the scenarios that you might encounter. But we here, I'm not sure whether you're familiar, I'm sure you might be, but in the NHS, what we commonly use for relaying information between healthcare professionals is what we call as SBAR, SBAR. S is situation, B is background, A is assessment, and R is recommendation. Whilst we do that, at the end, make sure that you're summarizing your case, whatever you have discussed, whatever advice you're being given by the opposite, by your senior, by your colleague, by your consultant, make sure that you rephrase it just to make sure that you got it right and you've not missed anything important that they've said. And I probably might forget, so I'll just mention it now. Whilst you're doing this scenario, because there might be a case where you want to refer someone or you want the consultant to come and see the patient, when you do that in your head, depending on the severity of the situation, depending on how bad the situation the client the patient is in, make sure you give the other person, the consultant, a time frame that you want him to address that problem in. For example, you want him to come there and then straight away. Just let him know. You've got 5 minutes, Dr. Jones. I want you to come down and see the patient. Mr. Jones, I think you've got 30 minutes for come to come. You've got good 30 minutes for you to finish from what I give you and come and see the patient. So basically give that, because it gives you that severity, gives you that understanding of how bad the situation is, right? Okay, so briefly talking about S, which is situation. When we say situation, it's about what is happening right now. Why have you been called? Why are you seeing the patient now? What wrong happened? Where did things go wrong? Why did the nurse want you to see the patient? So you briefly say the reason of the communication, why you have contacted the consultant. Hello, I'm Dr. Smith. I'm calling from the surgical ward. I'm calling regarding Mr. Donald. He's age 70. He's just become acutely unwell. He's acutely short of breath. So just introduce yourself. You're given who you are, where you are, and who you're talking about, and how old the patient is. And it's brief. It doesn't explain the whole scenario. It doesn't give the whole problem or the whole situation or the whole summary yet. But you're just giving a brief understanding, a brief explanation as to who you're going to talk about. Is a 70-year-old who has just been acutely unwell with shortness of breath. And then you give a brief background to it. So when you say background, it's basically relevant clinical information, right? And you might want to talk about a bit about his or her past medical, but only if it's relevant. Yeah. For example, uh, let me think of an example. For example, someone coming with you're thinking it's a perforated appendix, and you're saying that he is also complaining of calf tenderness or calf pain. Is it relevant? No, it's not. But a similar thing, a calf pain with chest pain might be relevant. So you would want to say that he had been complaining of calf pain and he's got calf tenderness in the last 2 days. You probably might say that. So only talk about those things that are relevant, that might make sense and add to the outcome, right? So, for example, you're talking to, for example, a microbiologist, and you want and advice about medication. So you want to tell them about, okay, yeah, this is a patient who's allergic to penicillin. You wouldn't want to say that to a random person, which is not relevant at that moment in time, right? So you said that Mr. Jones was admitted 2 days ago with, let's say, community acquired pneumonia, and he has got a background of COPD. He's on antibiotics, he's on oxygen therapy. Earlier today, he was stable on 2 liters of oxygen. Yeah, so you give a bit of background that he's been admitted 2 days ago. He was treated for this. He has got a background. He smokes. He was stable this morning, but he was still on 2 liters. He was still on oxygen, but he was stable. And then what you have done, assessment. A is assessment. What do you think the problem is? When you've assessed, you've done, in terms of your surgical, you do the ATLS and stuff, so airway breathing, and you've done examinations. So you think, you check the vitals, you think respiratory is this, SpO2 is dropped, or whatever, and patient looks cyanotic, he looks unwell, you're concerned. Why you think you're concerned? What do you think you should do? What is your recommendation? What do you want to happen next? And what have you done so far? They probably might ask you. It's not a simple one. They have a lot of questions, because it's definitely a professional conversation. It's a conversation between two professionals. They might have questions to ask you. So they might ask you, what have you done so far? What do you think is happening? Why is it relevant? Why do you want me to refer to this and that? Why do you want me to come? They're not easy. They try to be a bit difficult, but if you're firm and if you know what you're doing, you'd be fine. So recommendation is basically clearly stating what you want. Is it an advice? Is it a review that you want? Is it an intervention that you want? And what is the time frame like? How soon do you want it? Do you want to come them now? Do you want them to come now, or they still have more time? And just summarize it. I'm sorry, I'm not going through any of those specific scenarios that you might come across in the exam, but I'm just giving you an example, because um, uh, with the exam pressure, it gets difficult, it gets on your nerves, and I keep repeating this. Structure and practice makes things easy. You're very well versed with your theoretical knowledge and stuff. You might be able to do a lot of surgeries and stuff on your own, but in an exam setting, things are different. And just because, no offense to anyone, this is not our first language. So things get difficult when you're in pressure. So if you familiarize yourself with this, with certain mnemonics, with certain sort of structure, it could be anything, anything that you think suits you best. And there's no harm in like memorizing phrases. Even people, white people here, they for an exam, they prepare themselves. They go through like phrases that they can use in a review. It comes naturally to them. They're very fluent. They know how to be polite, how to like have that, not have that monotonous tone in their when they speak. So we as IMCs have to work on that, but it's not a difficult one. With practice, it can come. So I would say S bar is something you would want to stick to, with the one where there's a interaction between two professionals, and with the other you can create like your own whatever, whether or not you want to do ice in the middle of taking the history, or you just want to stick it to the end. And yeah, there's one more thing, sorry. For I think that you have yeah. See, there's one case here where there's a patient uh, who would want to discharge himself against medical advice, or not just that. There's any emergency, any discharge, any patient who you're sending back, or you think there's a risk that there might be a relapse. By the end of the consultation, make sure that you are what we call safety net the patient. It's very important. We often forget it's not rocket science again. It's like simply debriefing that you have had this. In case if you don't know about what are the adverse specific side effect symptoms that they might experience, but you could say if you experience anything adverse, anything concerning, go back to A&E, call 111, come back to us, go to your GP, whatever. You just have to tell them that, for example, P, for a patient discharged treated for P, U or MI or stuff like that. So you say that in case you re-experience these symptoms, or things get bad, you're short of breath, you're not able to breathe properly, and you're unwell, you always come back to us, call for help, 111, don't stay at hospital, come to A&E. So this is called safety netting, basically. What else? I think that is the end of it. I hope it made sense, and um, it is of some help to all of you. And any questions, I'm happy to answer if I can.
Thank you very much. It was very informative. Thank you. It was really was very informative. Thank you.
Great. I'm glad that you found it helpful. Thanks.
Thank you, Dr. Sabha, for such an amazing presentation. And I would just like your comment on the thing that, as in our South Asian countries, in Pakistan, India, Sri Lanka, Bangladesh, there are a lot of aspirants of MRCS. But as we do not speak, it is not our native language, English. So a lot of time we hear that kindly, please work on your tone, be polite, be polite. So can you help us with that, please?
Yeah, it's a good question. Yeah, I do understand. I do agree with you that we as IMGs um, do often struggle with this because definitely this is not our first spoken language. We don't speak English at home. This is not what we're used to, and coming to an English country, things might be difficult. But as I said, practice is the thing. Practice is where things make a difference, and when what we mean by that is that uh, I'll give you an example. A patient coming to me, and I'm approaching a patient, and I'm going to have to ask them question. For example, hello, good morning. My name is Dr. Sabha. I'm here to talk to you. Can you confirm your name and date of birth? Thank. Okay, even without saying thank you or whatever, I'll say, okay, I have a few questions to ask. Do you have chest pain? Yes. Okay. Any other symptoms? No. So we don't know how to pause, how it's a human sitting in front of you. So all you have to do is break it down, slow yourself, take that pauses, and just have that highs and lows in your tone. Yeah. For example, if your patient is upset about doctor, pain is really bad and it's just I don't like it. Say, I know, Jones. That might be really, really hard. I really understand that. But don't worry, we're here to help you. So that is where you bring it up, right? So just the flow. It sounds silly to be honest, but practice. I would say that's all I would say. There's no magic wand that would help you do it. It's when you speak it aloud. You have your partner, you have someone you're practicing with. You pick on things that you're not doing right, and you repeat it. I think you should be able to get through it. Hopefully, that answers your question.
Thank you, Dr. Sabha. Thank you. Yeah.
Hello, hello, Dr. Sabha.
Yes, yes.
I'm Dr. Billah. Dr. Sabha,
Hi.
when I'm hi, how are you? I'm fine.
Thank you. Yeah, go ahead.
I have a question. When we are in hurry, like when we are one sport to another sport, it
Yeah.
happens to me. Sometime for example, I'm no obviously I know myself, but when the patient's name and to whom I am going to, for example, I am representing Mr. John, and
Uh-huh.
if there is no name given there, Mr. Joseph or like this, I forgot that name. So is it influencing my uh, presentation to the examiner or not?
Okay, just to make sure, so are you saying that you're calling someone out by not their name, by a different name, although it's mistaken. You come out from a station which was Joseph, and now you've gone to a
Exactly.
different station which is John, and you've called John
Yes.
Joseph, and Joseph you called John,
Exactly.
and you're not aware of that at that time, right? And you realize it later.
Exactly.
Uh, so it's not very nice.
Sorry,
It's not
I'm
very
asking
nice.
you because in our setup names are not such like that, and
Okay,
they
don't
were
worry yourself with that. If this is something you think you might mess up around, for example, you're not able to in your head because obviously it's a time pressured exam, it's a lot of stress, and you're not very good and confident about remembering names there and then, and you don't have a template there which gives you a name of the patient. So don't worry about that. Don't worry. Say that that's fine. You don't have to call out them by now. It's basically that it's you rather not call them out by another name. Uh, uh, and then just say, sorry, I just lost track of that. So what I mean is that if you struggle to remember names, just you don't have to. It doesn't give you any. It in a way sounds pleasant. It gives you that feel. The environment there, the examiner there, the thing that okay, the conversation is, and even the patient engages a bit more well. But if you struggle with that and you think that you might mess around, you don't have to. You don't have. It's not necessary, I would say.
Okay.
Exactly, Dr. Sabha. Thank you for the
Excuse
answer.
me?
I will just like to add one thing, that in exam, if you forget, because there is a lot of stress, and if you forget the name of the patient, you haven't written it and you have forgotten it, you don't need to mention that, oh, I forgot the name of the patient. You got it? Just say, my patient, 23-year-old male, 26-year-old female, anything. Just don't mention the name. They are not going to ask you directly that what is the name of your patient.
Okay.
Also,
Yeah, I
I
didn't even.
wanted to add. Hey, G, please go ahead. Please go ahead.
Yeah, that's fine. That's fine. Hassan, you can. Yeah, continue.
Yeah, and I was also wondering if even if you don't remember the name, is it all right that we call the patient by his designation, as in if we don't remember the name outside the stem, when we read the stem outside the station, and then I was calling to talk to the IT registrar, or I was calling to talk to the vascular consultant on call, even if you've forgotten the name, rather than messing up the name, isn't it better to
Yes,
just to
of
call
course.
out the
Yes,
designation?
of course, of course. Yeah, rather than calling it no wrong name, it's just that you've spoken to your senior, you've
Yeah,
spoken to your colleague, you've spoken to a specialist. That's fine. Yeah,
absolutely. Yeah, thank you.
yeah. What I meant, sorry, if I made it a bit tricky for you guys, if I made it difficult and you got it wrong. What I meant by calling name is like whilst you're taking the history from the patient, it in some ways it sounds better. For example, someone calling me, Sabah, you came here for this, but at the same time, if you're not able to remember no names because you've got 15 or 16 stations, whatever, and you probably might not remember names for each of those stations for the patient, it's okay. Don't worry about that. Just forget about that. Forget that I said that.
Yeah, it's more of about building the rapport with the patient. Yeah. If you just
Exactly.
yeah
Exactly.
repeat recall out the patient's name every now and then after like 2 or 3 questions, just call out the name. It's just about being more
Yeah,
empathic and just having developing a better interpersonal relationship. I guess that is the essence of it.
definitely. Definitely.
Thank you very much for.
Any other questions, guys?
Well, thank you very much, Dr. Sabha. It really has been very informative and very helpful. Thank you so much for your time,
Thank you. Thank
and
you.
wishing
Hope you all
you
get through it
huge help.
and you're here as soon as possible.
Inshallah,
All the best,
inshallah.
everyone.
Thank you, thank you.
Thank you
Thank
so
you.
much, Dr.
Bye.
Sabha. Thank you so much. It was wonderful. It
Thank
was
you.
really wonderful.
Thank you.
Thank you so
Thank you.
much.
Bye bye, everyone.
So
Bye.
let's guys, so guys, let's sum it up, and inshallah we will try to make another webinar like this on some other topic, or on the similar topic also, inshallah. So let's call it off today. See you
Well,
guys.
see you. Thank you very much, everyone. Thank you very much for your time.
Thank you very much.
Thank you very much for your guidance once again.